Pediatric tibial fracture. Shin bone is made of two bones, the tibia and the fibula. The tibia is the major weight-bearing bone of the lower leg. The proximal portion of the bone, the tibial plateau, forms the lower surface of the knee joint. The distal end of the bone forms the superior articular surface of the ankle joint. The tibial shaft bridges the proximal and distal ends, and its anterior surface lies just below the skin. In children, both the tibia and fibula consist of a long portion of bone, the diaphysis, with growth plates at either end. Another fibrous structure, the crural fascia, surrounds the bones and muscles of the lower leg. Fascial extensions and the interosseous membrane separate the muscles, nerves, and vessels of the lower leg into 4 distinct compartments, and can be compromised by tibial injury. Nerves and vessels lie within the anterior, lateral, and the deep posterior compartments. Trauma that causes significant swelling in these compartments can result in neurovascular compromise. Tibial shaft fractures are the third most common long bone fracture in children, after fractures of the femur and forearm, and are accompanied by a fibular shaft fracture in 30% of patients. The mechanism varies depending on the age of the child, with low-energy falls and twisting injuries being more common in younger children, and high-energy motor vehicle accidents and sports-related injuries predominating in older children and adolescents. Children with neuromuscular diseases, osteogenesis imperfecta, or bone lesions are at risk for tibial or fibular fractures, even after trivial trauma, such as moving from a bed to a wheelchair. There are different fracture patterns in the lower leg, spiral and oblique fractures. Most of these injuries occur in children under 11 years of age when the child's body rotates around a fixed foot. Toddler's fracture, non-displaced spiral fracture of the tibia with intact fibula in a child under 2.5 years of age. Transverse fractures. These fractures result from a direct blow to the lower leg that is perpendicular to the bone shaft. Transverse fractures are the most common type of long bone fracture associated with abuse. Thus, child abuse should be suspected when the reported mechanism does not correlate with the degree of injury. Pediatric bones have a lower cortical mineral content than adult bones, allowing children's long bones a greater degree of plasticity. Thus, torus fractures and bowing deformities are injuries unique to the pediatric bone. Greenstick fractures are incomplete fractures involving disruption of 1 to 3 sides of the bone with bending of the others, akin to bending and splintering a tongue depressor without snapping it clean in two. Plastic bowing fractures are caused by axial loading that creates microfractures along the cortex and abnormal curvature of the bone. These fractures are more common in the radius and ulna, but may also be seen in the fibula. There are 3 types of tibial shaft fractures. Non-displaced, a fracture where the broken bones remain aligned. Displaced, non-comminuted, a fracture where the bones are broken in no more than 2 pieces but are not aligned. Displaced, comminuted, a fracture where the bones are broken into 3 or more fragments and are not aligned. A fracture is considered closed if the broken pieces do not pierce the skin. In an open fracture, the bone breaks in such a way that bone fragments stick out through the skin or a wound penetrates down to the bone. Children with tibial and/or fibular shaft fractures have pain, swelling and/or deformity at the site of injury. Most patients are unable or unwilling to walk. The only clinical manifestation of fracture may be erythema overlying the anterior tibia, which can be confused with cellulitis. Lacerations or other open wounds suggesting an open fracture. Tense swelling of the skin and muscles possibly indicating acute compartment syndrome. The following findings suggest a developing compartment syndrome. Increasing leg pain that is poorly responsive to parenteral analgesia. Increased pain upon passive extension of the toes. Cold leg and foot with poor perfusion, pallor and diminished or absent distal pulses. In toddlers, fractures, eliciting localized pain over the site of injury may be difficult, particularly in a child who is already crying. There is usually no swelling or deformity of the tibia to guide the clinician to the site of injury. In bowing fractures, often there is no swelling or minimal swelling at the fracture site. Plastic deformation is visible only with significant angulation of the fracture, although comparison with the unaffected side may allow detection of subtle differences. Children under 2 years of age in whom child abuse is suspected should undergo a skeletal survey to evaluate for other bony injuries. The doctor should palpate the posterior tibial and dorsalis pedis pulse and determine capillary refill in the foot. Neurovascular findings should be assessed in both legs. Plain radiographs typically suffice when assessing acute tibial injuries in children, and include anterior, posterior and lateral views. These should incorporate the entire length of the lower leg from knee to ankle. Anterior, posterior and lateral radiographs of the affected leg may show a faint hairline fracture, but this can be easily missed or inapparent on initial films in almost a third of patients. Occasionally, a child is brought to medical attention in a delayed fashion because of mild clinical symptoms and an unclear history. 7 to 10 days after injury, there may be healing and periosteal reaction on radiographs, which may look concerning for osteomyelitis or a bone tumor. In this case, a CT scan may be warranted to exclude a more concerning lesion. Treatment. When compartment syndrome is suspected based on clinical findings, immediate management includes relieving all external pressure on the compartment. Any dressing, splint, cast or other restrictive covering should be removed. The limb should not be elevated. Elevation can diminish arterial inflow and exacerbate ischemia. The patient should undergo fasciotomy with decompression of all involved compartments. In open fractures, in addition to pain management and immobilization, these patients should receive antibiotics and tetanus prophylaxis. Open fractures warrant prompt orthopedic consultation for operative debridement, reduction, and fixation. In patients with closed fractures and no sign of neurovascular compromise, the management will be as following. Casting is the mainstay of treatment for non-displaced tibial shaft fractures in children. Treatment consists of a long leg cast with the knee bent to 30 degrees for 4 to 6 weeks, followed by a short leg walking brace for an additional 4 to 6 weeks. The patient is ready for normal activity once full radiographic healing is demonstrated and the fracture site is no longer tender to palpation. Bowing or torus fractures are not displaced and therefore stable. Both of these fracture types completely heal when immobilized in a short leg cast for bowing fractures or a long leg cast for spiral toddlers fractures for 3 to 4 weeks. Children are usually made non-ambulatory for the first 1 to 2 weeks. After that, ambulation, as tolerated, is allowed. Early weight bearing as soon as 1 week after cast placement is not only safe but may be beneficial to the child's recovery without negatively impacting healing rates. Toddlers with a clear-cut history of trauma and an inability to bear weight on the affected extremity, regardless of negative radiographs, also warrant immobilization with a long leg splint or cast when a spiral fracture is the most likely cause for the symptoms until definitive diagnosis can be made. Such fractures usually become visible as a result of new bone growth approximately 7 days after injury. Patients with non-displaced tibial fractures may be discharged home with orthopedic follow-up in 1 week. For displaced tibial shaft fractures that have become angled, the doctor may be able to manipulate or gently push the bones into place without surgery. This procedure is called a closed reduction. Afterward, the leg is immobilized in a long leg while it heals. Most pediatric tibial shaft fractures can be treated without surgery when an adequate reduction is maintained. Acceptable reduction includes less than 50% translation, less than 1 centimeter of shortening, less than 5 to 10 degrees of angulation in the sagittal and coronal planes. Rotation is generally unacceptable. We suggest that patients who require closed reduction of a tibial shaft fracture be admitted to the hospital to monitor for signs of acute compartment syndrome for 24 to 48 hours. Tibial and/or fibular shaft fractures that undergo closed reduction should be evaluated by an orthopedic surgeon within a week. Subsequently, the patient is seen on a frequent basis for the first few weeks to monitor for any displacement or angulation. Loss of reduction may be corrected with opening or closing cast wedging. The child may need surgery if they have a more complicated or severe fracture. If the child is older than 5 and doesn't yet have mature bones, a surgeon may insert flexible nails into the bone through small incisions in the skin. These flexible nails realign the bone and hold it in place while allowing the bone to grow and heal. Typically, a cast is also used after surgery to help the bone heal. In patients at or near skeletal maturity, the surgeon may use a rigid nail instead of a flexible nail. For a more severe fracture, a surgeon may insert metal plate and screw into the bone. In open or closed fractures with extensive soft tissue injury, length unstable fractures or polytrauma patients, external fixation is indicated, using pins, clamps and rods to stabilize the fracture from the outside. Most children with tibial and/or fibular shaft fractures have excellent long-term outcomes. Up to 10 degrees of angular deformity of the tibia in the coronal or sagittal plane in children 8 years and younger remodels predictably. Rotational malunion does not remodel and may result in gait disturbance or abnormal limb appearance, which may require surgery. Accelerated longitudinal growth after a tibial shaft fracture and subsequent leg length discrepancy is less common than with femur fractures. But children less than 10 years of age and those with comminution are at greatest risk for overgrowth.